Good evening, everyone. You're very welcome to this UKFPO webinar, Making the Most of Your ePortfolio, Tips, Tools and Reflections. My name is Ruth Eakin. I am Deputy Director of the Northern Ireland Foundation School and also Vice Chair of the Academy of Medical Royal College's Foundation Programme Committee. With me on this evening's panel is my colleague, Dr. Debbie Cullen, Foundation Programme Director, or FTPD, in the Southern Trust here in Northern Ireland, and also Dr. Devon Ward, a Foundation Year 2 doctor in Liverpool and one of this year's UKFPO Fellows. So the plan for tonight is I will get my slides up and I will talk for as short a time as possible. And Debbie and I will both talk for as short a time as possible, and hopefully then Devon will have the lion's share of speaking time before we get to Q&A. And the chat, and I would ask you, encourage you very much to please post messages, post questions in the Q&A or the chat so that we can discuss them at the end. And behind the scenes, we're most grateful to Kata and Tamika from the UK Foundation Programme Office, who will kindly help to ensure things will run as smoothly as possible. So first of all, what ePortfolios? And in case anyone is not aware, there are two ePortfolio platforms in the UK Foundation Programme, HORAS and TURAS. HORAS is used in England-only foundation schools and TURAS in Scotland, Wales and Northern Ireland. They may look a little different, but they do exactly the same thing. So portfolios have been in use for almost 20 years now, following the introduction of MMC, Modernising Medical Careers, way back in 2005. And the aim of that was to reform postgraduate medical training and thereby improve patient care by providing better quality education. So the primary aim continues to be to promote learning, and we all use portfolios in one form or another. They provide a space to log evidence which ultimately documents progress. Reflective practice is really important, and this is about considering specific experiences and so gaining insights. What did you do? What did you do well? What could you do better next time or not so well? And together with feedback from supervisors, including in their end of placement reports, and from others around you in the workplace, this combination provides the basis of continuous learning and growth, which is central to the foundation curriculum. Personal development plans, then, they're there to keep reminding you of what you want to achieve within a specified time frame. And of course, then everything is there to help you with interviews, CVs, and moving forward in your career. And from my point of view, our responsibility as a foundation school is to ensure that we take newly qualified doctors straight out of medical school and support and guide each and every one to gain the required competencies in the clinical and professional arenas, and at the same time enabling each and every one to be able to deliver safe and effective clinical care. And then at the end of the 2-year foundation programme, to be at the required level to be able to apply to higher specialist or GP training. And the ARCP panel, the annual review of competency progression, is there to make those judgments fairly and based on what's in the portfolio only, hopefully giving an outcome 1 to F1 doctors so they can gain full GMC registration and proceed to F2, and likewise an outcome 6 to F2 doctors to be able to award an FPCC Foundation Programme Certificate of Completion, after which then on you go confidently onwards and upwards in your career. The important thing to remember is that the ARCP is a pure portfolio review. So the panel looks at all the evidence, when it was uploaded, the content and the quality of it, and using the ARCP checklist, which I'll show you in a moment, will then make a judgment as to whether the requirements have been met or not. And if they haven't been met, the panel will set out why, what needs to be done, and how much, if any, additional training time is required to achieve a satisfactory outcome, and thereby allowing progression to the next level of training. It is an outcomes-based curriculum, and everything that needs to be achieved is clearly laid out up front. I'm sure you're all familiar with the 3 higher level outcomes and 13 foundation professional capabilities, which I'm not going to go through, and that there is a hierarchy of evidence with experiential supervised learning events carrying the most weight at the top of Miller's pyramid. Next down is simulation, followed by core learning, which is foundation doctor specific teaching. and non-core learning, which is teaching to a mix of grades with e-learning and reflection at the bottom, but no less important. And as this is a foundation program, it's entirely appropriate that learning should not just be about physical health, but very much also about mental health issues and, of course, social well-being. As you know, most medical care takes place outside the acute hospital. So evidence of learning about chronic illness and community medicine across the 13 FPCs or Foundation Professional Capabilities is also essential. So very broad requirements, rightly so, at the beginning of your career as a doctor. And there are carefully chosen core topics that all foundation doctors should be taught in, first at F1 level and then again at F2 level. And they've been chosen for good reason. They're maybe hard to learn about in the experiential setting, or they're new or historically not well taught. And there is a requirement to have a minimum amount of teaching, whether foundation doctor specific, which as I say is core learning, or along with colleagues in different grades and other professions, which is non-core learning. And this also includes reflection and e-learning. I've already mentioned the importance of reflection, but e-learning has a significant part to play as well, so that over the course of the 2 years, your learning and growth not only happens in different ways, but it is also recorded and documented for you on your portfolio and for your supervisors, and of course for the ARCP panel. And there are assessments for learning or formative assessments, and these include the summary narrative, which is a specific reflection designed for you to add additional evidence of achievement and learning, with one for each HLO. And actually, in a few weeks' time, you'll be able to start them and you'll be able to write about the pieces of evidence that you've already linked to the FPCs, what has gone well and maybe not so well, what you've learned from, and what you need going forward. You can discuss these narratives then with your ES at the end of placement meeting, and they can help to inform your PDP going into the second placement in December. Writing these summary narrative reflections also sets you up for moments of global reflection on your progress in general. And we all need to do this from time to time, and you'll need to do it as well throughout your career going forward. And there are assessments to ensure learning has been achieved, or summative assessments. And the clinical supervisor's report at the end of each of your placements is the bedrock of documenting capability in the workplace. And it's probably the most important summative assessment. So please make sure you have dates in the diary for meeting your supervisors at the end of each placement. Your clinical supervisor needs to comment on what's in your portfolio for that placement, as well as on any feedback from the team around you. And then they make a judgment about your overall level of performance. And then your education supervisor reports on a broader view of your progress and what's in your portfolio, including what's in your CS report. And both of these for each placement are essential for the ARCP panel to be able to give a satisfactory outcome. So this is the checklist, if you haven't seen it before, with the summative assessments I've mentioned here, and also the PSA for F1s, and the formative assessments here, including the feedback tools, the PSG, Placement Supervision Group, and the TAB, Team Assessment of Behaviour. Please note that this is a contemporaneous portfolio. This is actually a requirement. There it is in the ARCP checklist. And as this is the second half of October, hopefully you're already building up some evidence. So SLEs, you're maybe aiming for 5 to 10 SLEs per placement, some teaching that you've been to, some e-learning that you've done, and of course, regular reflections. So in a few weeks' time, you'll be ready to start your 3 summary narratives in preparation for your CS and ES report meetings. So that is a very brief overview from me. I'm now going to hand over to Debbie, Foundation Supervisor's View. Thank you very much, Debbie.
Thanks, Ruth. I'm just going to share my slides now. Okay, great. So hopefully everyone can see. So again, firstly, thanks to Tamika and Kata and the UKFPO for allowing me to come and chat to you all this evening, and Dr. Egan for her brilliant presentation. So just to introduce myself, I'm Debbie Cullen. I'm Foundation Programme Director for the Southern Trust in Northern Ireland, which is 2 district general hospitals. And I also work clinically as a specialty doctor in critical care medicine. And I've been asked really to come and speak to you this evening about the ARCP panel and how we conduct ARCPs locally in hospitals and trusts, and just to try and demystify that a little bit for yourselves as foundation doctors. So I think to start, probably what is an ARCP and what does ARCP actually stand for? So an ARCP is an annual review of your competency of progression. So really what that means is allowing us to see, are you at the training milestones we would expect for you finishing your F1 year to progress into F2, and indeed at the end of your F2 year to complete your foundation training. And what we do as a panel, we review all the evidence that's in your respective portfolios and also your achievements over the course of the year that you've documented, to make sure that sort of meets the training requirements for the year and the ARCP checklist, which we'll talk about in a minute. Your portfolio and your evidence is reviewed by a panel, and that's usually done locally in your trust or hospital. But around 10% are carried out your dean or your foundation school, and that's really for quality assurance purposes, to ensure that we are standardized in our approach. Your ARCP happens at regular points throughout the year, and for the majority of trainees, we would expect all your evidence to be uploaded on your portfolio, usually by the end of May, for an ARCP to be carried out in early June, usually within the first few weeks. There are some exceptions to that for trainees who are out of sync for various reasons, whether maternity leave or less than full-time trainees who have different timescales for their progressions in training. But as I say, for the majority of trainees, your ARCP will be early June, and you tend to be notified about what date that will be carried out via email by your foundation program director or your deanery. So the ARCP outcomes, so it's not a pass-fail. We kind of give you numbers for what we would expect, and I know Dr. Eakin had mentioned them in her talk as well. So I think the two big take-home points are what are the outcomes that you want to get. So an outcome 1 is the outcome we would like you to get at the end of your FY1 year. And that means that as a panel, we're satisfied that you've met your requirements and you can progress into F2. And outcome 6 is what we would like you to achieve at the end of your F2 year. And that means that you've completed your foundation training, and we're recommending you for your foundation program certificate of completion to allow you to apply for further specialist training and progress into the next stage of your career. And there are outcomes between 1 and 6. You'll probably notice there is no outcome 2 in this slide, and that's because there is no outcome 2 awarded to foundation training. So the other outcomes, and outcome 3 is that we feel you've had inadequate progression for various reasons, and the panel would recommend that you need additional time in your training to meet the requirements of FY1 or FY2. Outcome 4, I'd just like to reiterate that outcome 4 is exceptionally rare in foundation training, and that is released from the training programme, and that would require meetings with your foundation school director. And the other outcome that we can award is an outcome 5. And outcome 5 really means that you've presented incomplete evidence. And usually that will be things like you're missing a supervisor report, or there's some pieces of evidence which as a panel we feel have maybe been missed and could be gathered reasonably quickly. And if you receive an outcome 5, we usually give you a time scale up to 2 weeks to gather that evidence and upload it to your portfolio. And then we'll reconvene a panel. And if you're still unable to produce that evidence, an outcome 5 usually transfers to an outcome 3, and you will require additional training time. But on the flip side, if you are able to produce that evidence and the panel are then satisfied, then you'll either receive an outcome 1 or an outcome 6. So I know we've talked a little bit about the evidence that we expect you to gather in your portfolio, and how do we assess that? So there's lots of things that will be on your portfolio. Supervised learning events include mini KEXs, directly observed procedures, case-based discussions, amongst other things. As a panel, we look to make sure that those pieces of evidence meet all of the 13 FPCs and the curriculum requirements, and that you've linked them appropriately and the evidence matches what we would expect. A big part of an ARCP is a judgment by the panel, and we really do take into huge consideration your end of year report from your educational supervisor and all your end of placement reports from your educational and clinical supervisor. along with the body of evidence that you yourself have uploaded and presented. But I would reiterate those meetings with your supervisors and their judgments, as they're the ones who will be supervising you throughout the year, are really vital. And the ARCP checklist, which I know Dr. Eakin had mentioned, is available on the UKFPO website. And if you're struggling to find that, I'm sure your local medical education teams will be able to provide you with that as well. I think it's a really good tool, and I would recommend at the end of each of your rotations to have a look at that checklist and make sure that you're really on track of where you want to be in your training year. And I would always say that the evidence that you upload, don't upload everything in a rush at the end of placements or at the end of the year. We do like everything to be contemporaneous and we can see the dates things are uploaded. So try and do it often rather than in a rush at the end. So I talked a little bit about the panel. So who actually makes up an ARCP panel? So an ARCP panel is made up of a minimum of 3 people. 2 of them will be clinicians and 1 medical education administrator as a minimum. And of those clinicians, usually 1 will be a foundation program director or a foundation school director, plus someone with an educational role, an educational supervisor. Not necessarily your educational supervisor, but an educational supervisor from the trust or foundation school. We don't expect you to attend your ARCP panel in person either. So the panel meet and will award you your ARCP outcome. There may be times that we request you to attend to receive your outcome and discuss the recommendations that the panel have given you. And that would usually be for an outcome 3, 4, or 5. And you'd normally be requested to attend either in person or virtually. And that really is just to receive the feedback from the panel and to discuss the recommendations that we have given to help you progress in your training. And for an outcome 5, you will be contacted as well. And as I said previously, given up to 2 weeks to provide that supplementary evidence for a repeat panel to be convened and see have you provided adequate evidence to progress. And how do you find out your outcome? Because we meet as a panel, but how do we tell you as the resident doctor? So following your ARCP, it will be uploaded to your portfolio. That'll either be TrueAS or HORAS, depending which school you're in. And you'll also be notified through the email address that you've provided on your portfolio via the portfolio software, and also your medical education teams will normally let you know. I would say if you haven't been invited for feedback or recommendations, but you still have some queries about your outcome or want to discuss your ARCP, I would say reach out to your educational supervisor or your foundation program director to arrange a meeting. But most importantly, I would say use your portfolio wisely and enjoy your foundation training. And your portfolio can be there to celebrate all the great things that you've done through the year, and let us as educators see all the great things that you're doing, because we don't necessarily see all the day-to-day brilliant things that some of our foundation doctors are doing. So I would say enjoy F1 and F2, use your portfolio wisely, and I wish you all the best for your future careers. So my talk's really quite short and sweet, so I'm going to hand over to Devon now and let her talk you through all her top tips.
Brilliant, thank you, Debbie. I will get my screen up here as well. Is that all? Is that up? Brilliant. So hi everyone, my name's Devon. I'm one of the Foundation Year 2 doctors at the moment. And essentially I'm here to give you more of an insight to what it's like as an F2 who just went through the F1 ARCP and what advice I would give on the e-portfolio. So this is basically what I'm going to go through, what it was like for me, my advice, and a few examples. I think the examples are useful just because there's not many examples of what a portfolio actually looks like online and how people write reflections, so I've included some of those, so hopefully they'll be of use to you. So when it came for me and starting the e-portfolio, this was my initial perspective of it was that there's a lot of stuff on it. There's 13 individual things split up into 3 HLOs. It felt like a lot of requirements. I know that some trusts give you recommendations on specific numbers per form as well. I didn't have that in my hospital, but I was aware of it happening in other places. And I just thought, gosh, this is one more thing to do on top of trying to learn how to be a doctor. And I've said saving lives to show my overall strength. But when I started actually doing it, the more I found it was like, I actually found it really useful. I think I've put some things here that not everybody really sees in the portfolio that I want to share with you. I think first it's a repository for all your achievements over the course of the year, both in and outside of medicine. It's a way of identifying things that you're really good at and the things that you enjoy, but also a way of identifying areas where you're not so good at and what you can do next. I think my best example of this is I did on an on-call shift, I came across a patient with an exacerbation of bronchiectasis, and I had just completed a respiratory job, and I thought, aha, I know how to manage this. And I did. I did all the acute management of the patient, and then I spoke to the medical registrar just to let them know, like, by the way, this is an unwell patient that I've been managing. And I got some really useful feedback. They said my management was great. But I missed out about chest physiotherapy. And chest physiotherapy in bronchiectasis is vital. It's almost as important as giving any of the nebulizers or the antibiotics for infection. And it was just a big blind spot for me in my management. And I promise you, I will never forget doing chest physio referrals for patients with bronchiectasis because of that discussion. So I think it's really useful. I also think it's a good way of being able to access things like your audits, QI, anything that you've got involved with where you can access them at a later date. So I can now, when I'm preparing my stuff for specialty portfolios, I can look at my Horus, because I'm in England, or you look at Turas, and I can see, oh, I did this teaching session on this date. I can include that in my application. And of course, it is a way to pass the year, but we're going to focus on other things. That's sort of to the side. In terms of my advice for the portfolio then, these are the 4 things that I will say. Start early, start smart, ask for opportunities, and don't undersell yourself. And I'm going to go through each of these individually. In terms of starting early, I know it's October, so we're not too late or anything like that. But what I mean is that this is that ARCP sneaks up. It's about halfway through your 3rd rotation. And so we think that we have to do it by the end of the year, but actually you have 2.5 blocks before you need to do it, which is about 42 weeks from when you started August. Now, I always say to people that you have the absolute most to learn in your first placement, and therefore the most to reflect on, because the first time that when you interact with patients and you manage stuff, it will be the first time that you as a doctor have managed that condition. And therefore you have lots to learn from it and lots to reflect on for it. It is different to see something as a medical student as it is to see it as a foundation year 1 doctor. Those are different things. I tend to use this sentence that I've put on the board here, or something, or a version of it, which says, this is the first time I've managed whatever the condition is. Do you mind if I send you a form so I can reflect on it? Sometimes it might have been the 2nd or 3rd time that I've managed it, but I still think it's a good learning opportunity. So don't think that just because we're in October, they're a little bit down the line. This applies in August, particularly in this first rotation, but every time that you start a new placement, you're going to see different conditions. I moved from respiratory medicine onto upper GI surgery. Trust me, the patients that I was seeing were completely different. And so even if you feel like, oh, I'm not doing first time management of anything now, you've got that coming up again in December. So don't feel like I'm still doing it in F2. You can also just say this is the first time I've managed somebody in this specialty, even if the condition is one that you've seen before. And I've also put here, in terms of a tab, so that team assessment of behaviour, I recommend that you make notes of the names of people throughout the placement, even before you send out the form, because once you send out a tab form, you've got a couple of weeks before it closes. So what I do is I call it my creepy book of names, where I write down everybody that I've interacted with, and I think that we've had a good relationship. I say, would you mind giving me some feedback on the way that we've worked together today? And I get their email address. And that way, when it comes to the point of me needing to submit a tab, I can go to my creepy book of names and I can say, okay, well, I need 15 people from here. Who am I going to select? And to be fair, I send it to everybody. But this is usually what we end up doing, though, a sort of fairly realistic timeline where we don't really do anything in August because we're trying to just settle into the job. And then in September, you go, oops, I need to do something for my portfolio. And then you think, oh gosh, I'm settling in again. You don't really do much for October. In November, you maybe bash out a mini kex, maybe adopts in January. And then you go, oh my goodness, ARCP is just around the corner. And then you smash out everything else that you need for your portfolio just at the end of April. Do a summary narrative at the end and then ARCP and off you go. Now, obviously, this is not the ideal. This is just what, and it's probably a little bit of an exaggeration as well. But in terms of what we want to see as more of a goal timeline and what we're trying to aim for, these are some things that I'd challenge you to try and include as you're trying to put together your portfolio, to see if these help in trying to make it a more consistent thing over the course of the year. I really recommend a post-placement reflection, which I think we should be reflecting all the time. Anytime that you start thinking about, oh, this day wasn't so good, or this day did go really well, that's a really good point for a reflection. But if you want set points, I think post-placement reflections are good. This is where you come to an end of your rotation. You can just look back over the last 4 months and say, well, how did my placement go? Did I like it? Did I not like it? What was the most useful thing that I learned out of it? And you can take that down the route of a skill. You can take that down the route of communication. You could take it out the route of, I watched a DNA CPR discussion. Equally, what wasn't so good, you can do that too. And you can also talk about in this reflection whether you feel like this is the career or not for you. For me, for example, I've did 2 surgery rotations in my F1 year. Neither one of those is what I was interested in. But my post-placement reflection said, whilst I enjoyed doing X, Y, and Z, urology isn't for me. But then I can map it to my, is it FPC 12, my career planning learning objective, to say that I've thought about what the future's like for me. As I've mentioned already, I try and sign off the first patient that I present of any condition, but also in every rotation. So when I started in ED, for example, in F2, I said, hello, this is the first time that I've presented a patient. Do you mind signing me off? With the goal that at the end of my rotation, I can say, this is the last patient I will likely clerk in the emergency department. Would you mind signing it off so I can compare and see how far I've come? Hopefully, I got better. I've then written in, depending on trust goals, because some specific hospitals have specific goals for you to hit. But I personally aim for about 2 of each of your supervised learning events per rotation or per block, meaning 2 CBDs, 2 DOPs, 2 mini kexes, 2 DCTs, 2 leaders, whatever, etc., etc. The reason that I aim for this is that if I keep that in my head of trying to get 2 of everything, by the end of the rotation, I feel like I've got a well-rounded portfolio. Now, I don't always meet that target, and the UKFPO, I think, recommends 6 SLEs total per rotation to make sure you got a full portfolio. But if I have a target of getting 2 CBDs, 2 DOPs, 2 mini kexes, even if I only manage to get 4 or 5 out of that, or in a different rotation I managed to get 8, I know that I'm about at my baseline, and I can try and get an ARCP outcome 1 from that. I also recommend to write your summary narrative at the end of each of your blocks. And I would say write about 80 words. The reason that I say this is because a summary narrative is supposed to be this narrative discussion of what's happened to you, how your portfolio has developed, that's going to get you to the point of passing your ARCP at the end of the year. And I just feel like that's so much easier to write when you've just had those experiences. It's really hard for me to look back on a mini kex that I did in September of 2024, and say, oh yes, at that time that really helped me develop so and so, because I just don't remember it. And so I'd recommend write it for each of your 3 summary narratives, a little update, and about 80 words. I say 80 words because you've got 3 rotations, it's 300 words, 80, 80, 80, and then you get a little bit of extra words at the end just to sort of tie it all together. You might change it towards the end, and I think that's reflective practice, isn't it? Going back and saying, actually, that wasn't the best example of how I did that, and changing it. But that's what I start off by doing. I recommend doing your e-learning early, and we'll go through, I'll tell you about that in a second. And I've also said, know when your breaks or your holidays are, because you're just not going to do much in terms of your portfolio on that when you're on annual leave. In fact, you shouldn't do any of it on annual leave. You should do it on your self-development time or your study days. So it should be entirely separately. But if you know, for example, that you have a religious holiday that happens in December, and therefore you're going to have 2 weeks off, probably not the best time to think, oh, that's when, don't worry, that's when I'll do all my portfolio. So just keep an eye out on that, and just know where your periods are of up and down, where you're likely to be able to do some. And that should resolve in something that looks like this, very busy. What I'm trying to show with this is that if you're able to do little and often, so there should be no period here where you're suddenly doing 4 CBDs in a month. That's a lot. But if you look at what I've put in September there, for example, a mini KEX and a DOPS, 2 SLEs in 1 month, that's once every 2 weeks. That's doable. That's doable. Yeah. I've put a few things here about some other stuff, some e-learning reflections would be in here. I'd probably pop those as you see at the bottom, end of placement reflections 3 times at the end of each of them. You could also do a pre-placement reflection, but I think that's better put in a personal development plan personally. Yeah, so that's what we would aim for, little and often. And it may be that you've not done anything yet since you started in October, and you might have to make it a little bit more tight at the moment. But eventually you should be able to hit into this maybe 1 to 2 a month. The next thing I said was about starting smart. And what I mean for that is I'm very much a proponent of working smart, not hard. And that's what I mean here. Like, you aim for 2 bits of hard evidence for each of your FPCs on the e-portfolio, right? So your e-learning counts as hard evidence, and each of your things that you put on your portfolio can be mapped to 3 FPCs. So if you can identify overlaps in your topics for your e-learning, then you can reduce your workload to start with. I'll show you exactly what I mean by this. This is a screenshot of Horus. Now, Turas does have a button like this. It just looks slightly different, and I don't have a Turas account. So hopefully you'll be able to relate this to your own experience. What I'm trying to show here is in that top right-hand corner, there's a big red circle where I've circled where it says ELF, which is e-learning for health, right? If you get rid of all the other things where it says show me, click off guidance, mapped evidence, descriptors, and you just click the ELF bit, the e-learning for health, it then splits all of your FPCs and shows you all possible e-learning on the e-learning for health website that you can map to those FPCs. So for example, this one here, medication history taking and prescribing on admission, is an e-learning module that you can map to FPC1. What I want you to take a look at is trying to find those ones that have overlap with multiple FPCs. I have given some examples here, and I've just gone through that list on my Horus, and I've identified some where you could map it to multiple. For example, selection of investigations, you could do it as a 20-minute module. You can map it to FPC 1, 2, and 3. And then I've put others where at the end of it, you will have mapped everything from FPC 1 through to FPC 13 by only doing 5 e-learning modules. If you did that, 20 minutes, and there's 5 of them, so you spend about 100 minutes, almost 2 hours. If you spent that on your self-development time or a study day, you would have half of the hard evidence that you need for all of your FPCs done in one fell swoop. Now, I don't recommend just having 2 bits of evidence mapped to each of your FPCs, but this is a really good starting point, and this is what I mean about starting smart. If you start and you have this to begin with, then you have less to worry about going forwards. I did this to start with, and then in about January, I went back through my FPCs and I thought, okay, I think that there's actually better e-learning here that better demonstrates my ability to do FPC2, so I'm going to do that instead. And so I did change it towards the end, but I started like this, and that takes a real weight off. when you already know you've got one bit of hard evidence for everyone. I've also then added here, relate your reflections to FPCs when you write them. And I'll show you what I mean by that. I mean, when you are writing your reflection, this was for a CBD, I have then, in brackets after everything, put which FPC I think that relates to. For example, in my first sentence, I say, I did this immediately to ensure I was being an active team player, blah, 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 brackets FPC 6, because FPC 6 is about team working with members of the multidisciplinary team. Does this mean that my reflections take a bit longer? Yes, because I need to know what all the FPCs are, and I don't know them all off the top of my head, and I do have to relate them to each other as I'm going through. But it means that when I come to map this CBD, if I'm thinking, gosh, I have absolutely nothing mapped to FPC 5, I can look at this one and say, oh, actually, I could map this one to FPC 5. And it makes that process of making sure that you have evidence spread evenly amongst your portfolio a little bit easier. I've also just highlighted here at the bottom that I have done a little full circle, little loop of the reflective cycle where I've said my moving forwards, I'm going to include fluid balance in my documentation. And then I've linked that to an e-learning, which I found on the e-learning for health list on Horus or on Turas, that I can map to some of my FPCs. So I finished this CBD with being able to map it to 4 different FPCs and with an e-learning that I can then potentially map to up to 3 more. I'm hoping this is making sense about what I mean by starting smart. I'm trying to just hit lots of different boxes with one learning event. I'd also recommend that you ask for opportunities. And I mean this in the sense that despite that your seniors have supervised lots of people at your level multiple times over the years, they still somehow don't really know what it is that you need without you explicitly telling them. That's because sometimes our goalposts are shifting, but us individually as doctors, we have different things that we need to meet. And so tell people what it is that they need to do. When you meet with your educational supervisor, say, I want to learn, I'm going to give an example here, I'd really love to learn X skill in this rotation. I really want to learn how to put in chest drains. What can I do to make this happen? When you meet the consultant at the beginning of a week, if you're really keen, you want to do something, ask one of these questions. I'd like to get a CBD in this week. Would you mind if we review a patient individually and discuss? I think these questions are a really good baseline for you to ask so that you can take an active role in your own development. I've said here about asking if there's clinics, asking if there's theatre opportunities. And I think the last one's particularly important is if you want to specialise in that specialty, or even if you're just considering it, ask one of the seniors in the specialty, what experiences do I need to get in this rotation to prepare me or to prepare my application? That's always good because firstly, you will highlight yourself to that senior as somebody who's interested. And so when they do have an exciting opportunity, they'll think of you first. And also you'll just get to listen to somebody speak about a specialty that they're hopefully passionate about because it's what they've ended up in. And then you're able to get on board with any projects or clinics that they're doing. I've highlighted at the bottom, you're not a burden. I think we often feel like asking for opportunities, it's very self-centered and it's not really focused on the service provision that we're providing. But your portfolio won't develop and you won't develop unless you're pushing and asking for it. So I'd really recommend asking some of these questions. I've provided here some common opportunities that I think map nicely to different forms. For example, doing a presentation at weekly departmental teaching. It maps to a developing the clinical tutor form, whereas teaching medical students on the ward and getting informal feedback from them is a teaching other form. The difference being the formal feedback from somebody else watching you. I've written here about ADOPS, about asking a nurse to shadow you doing catheters, cannulas, bloods. The reason I've popped that on there is that I think that often we think that only other doctors can sign us off for skills, but it's just anybody who's competent in doing that skill can sign you off for ADOPS. So if somebody's more available to you and is competent in that skill, there's no reason why they can't fill it in for you. If you discuss a patient with a senior during an on-call shift, I think that's a really, really good learning opportunity because you're often going to be asking for help because it's an on-call shift and we always are, there's a really good opportunity for a case-based discussion. If you have medical emergency teams or MET calls or crash calls, there tends to be a lot of people in the room when you're doing that. I think that's also a great opportunity to do a mini KEX because your behavior was observed. And I've put here, we are very commonly asked to re-prescribe medications. Oh, this patient's regular medications are on there wrong. Can you do them again? Or, oh, this person normally takes 40 of omeprazole, but they're on 20 at the moment. Do you mind changing that? And we just do it because that's a very quick and easy thing. But I think that's a really good opportunity to do a reflection because what you're asking there is about prescribing error. And I think that's a good point for reflection because how many times are you asked to do that throughout the day? And what do we think about it in that way? There's also an e-learning an e-learning for health module called medical error when things go wrong, which you can then relate that reflection to and then continue a reflective cycle. I think a lot of people get worried about the audit quip side of it. I don't know if it's actually that people struggle to get the audit when they're looking for it or they're just nervous about starting it. But I thought I'd just talk about this in a bit more detail. So in F1, you just need to demonstrate that you've been involved in like an audit or QI process or rather than design your own one. Whereas in F2, you need more active involvement. For example, leading one, but it doesn't necessarily have to be. I have two recommendations, and hopefully this will help you get started and be involved in that process. First, I would reach out to your supervisor. That can be your educational or your clinical supervisor. I appreciate for the F1s listening, they're probably the same person at the moment. They'll reach out to them and ask to get involved in an audit or a quip at the time. So at the beginning of a rotation, I think it's a really good time to do it because it means you've got 4 months working there. But I started my first audit in late September of my first rotation, so it doesn't need to be right at the beginning. Ask them if they got anything ongoing and see if you can get involved. And then if not, I would recommend designing a simple audit that can become a quip. Now, what I mean by that is what you need to do is go to your ward, as you all are, I hope, and just listen to what people complain about on the ward. Because what people are complaining about is what is going wrong. Then reach out to your educational supervisor, your clinical supervisor, or just your favorite consultant and say, would you mind supervising me doing a project on whatever the problem is? Once you've done some data collection, in theory it's bad because people are complaining about it. And if it's bad, you can make an intervention to make it better. And now that's a quip. And if you do that, that really nicely completes that. It becomes an audit cycle, doesn't it? It really nicely completes that. And you can just keep that rolling. To relate it to my experience, I had a consultant that just complained constantly about the prednisolone prescriptions on the ward for exacerbations of COPD. And I thought, well, what should we be prescribing for ECOPD? And it says 30 milligrams for 5 days. And I was like, okay, that's what NICE says. So I went to my favorite consultant and I said, hello, would you mind supervising a project of me looking to see what we prescribe for patients with exacerbation of COPD? Is it 30 milligrams for 5 days? The answer was no. We prescribed it for about 16% of the patients. So then I went, okay, how do we fix that? I did a teaching session. I did the classic, made a poster. And then we did it again and it improved to 32%. Brilliant. But that's still not that good. So we did another teaching session and it improved to 41%. And now we're doing 2 cycles, all from one consultant I came across complained on a ward round, right? And so it doesn't need to be this big ground changing thing. But at the end of the day, if we're improving the prescriptions alongside guidelines, we're improving patient care. And that's the whole point of auditing QIs. Hopefully that all tracks for everyone. Lastly, don't undersell yourself. And I think it's a really important one for F1s because for doctors generally, because I think we always have massive imposter syndrome. But developing your core competencies, and if you read through those FPCs of F1, It doesn't just mean doing medicine and things inside of medicine. There's lots of ways that you can develop all of these skills outside of medicine in your extracurriculars. You can develop your team working abilities in sports. You can do well-being in yoga, crochet. You could understand the impact of bias working in a charity. The important thing is that a reflective process that happens to make you a good doctor will include everything that happens to you on the wards in your role as a doctor, but will also include everything that you do outside. And so all of your achievements you can include on your portfolio. Use your portfolio to show all of the extra stuff that you do, as well as this. It's also useful to have this for specialty applications, to say that you've done it all in one place. And I'm not saying that necessarily loads of people in the audience are Olympic gold medalists. Put that on your portfolio. If you are that, do. But things like if you have started exercising, if you took up a dance class, if you started a language, it doesn't need to be that you are the best in it, which is what we often aim for in medicine. It's just that you're doing something, you're trying. It's personal development and it's personal improvement. I've just provided some examples here of what my portfolio looks like, and I'm just going to explain to you why it looks like the way it does. All of the forms that you have to do will have, please reflect on it, as like a little box, right? You can use something formal like Gibbs Reflectives Recycle that I've put on the left-hand side. Given that I do the thing with the FPCs and then I read through the list of the e-learning at the end of all of mine, I point to the e-learning that I'm doing and I put all the FPCs in brackets and all of that. I find this reflective cycle a little bit much for me on top of all of that other stuff. I use a slightly smaller version of it. What I would recommend is just look at different ways of reflecting. You'll find one that works for you. Personally, I use this what happened, what did it mean, what next? What happened being the actual series of events, and I relate it to the FPCs. I saw a patient with infective exacerbation of bronchitis. What did it mean is what impact did it have on you, on your patient, on your future practice, on your training? It highlighted to me I didn't know anything about chest physio. And what next? What will you do to improve for next time? I will do some e-learning on more holistic management of patients, because there's one called holistic management on the e-learning for health list. That's what I do. I'll show you how that works in practice. What happened? What did it mean? What next? This is what I would write for a mini KEX, and I think I was being particularly in depth that day because that's quite large. The majority of what I've said is what happened. I find this bit the easiest to write. I think the majority of people do, because you don't need to think. It's just physically what happens, how does it relate? What did it mean? I then put in that yellowy color underneath, and you can see that I'm trying to relate why it meant something to me. It's a little bit harder. And then what next is then what is my next step in terms of my professional development. So this one here, I've just said I need to do more stuff on catheters because it's part of my personal development plan whilst I'm on urology. And then I wanted to review bladder cancer. I didn't put a specific example this time. Naughty Devon. This one here, a little bit more typical for what I write for a CBD, or typically for a reflection. What happened at the top? I followed that with, after this consultation, why? What did it mean to me? And I had missed, it's the one I provided earlier, I missed out the importance of the fluid balance side of it. And therefore, going forwards, what next is the bit I've put in green is, well, what do I need to do? I need to start seeing the importance of fluid balances. I need to do e-learning. This was quite big to me. I did a separate reflection form on it as well. But you can see I've written, he had significant losses through the catheter, riles, and drains. He was significantly dehydrated and I missed it. And so I did a separate thing on it as well, but I put 2 e-learnings that I wanted to do because I just thought that this is clearly a big gap for me. And then I said to do it in the next 2 weeks because I like to make them SMART goals, my timing. And lastly, same thing I do for a DOPS as well. I think a lot of people skip the reflective bit on a DOPS and make it really short, but the same thing applies to, it's still a reflection. And so again, what happened at the top? What did it mean? What next? This one here, doing an ABG. And it shows here like something that I changed to my practice, and what did it mean about the angle that I was using for an ABG needle. And then I've put in my what next. And this time here I put about specific practice requirements. I was on a respiratory ward. 1 ABG per week was very doable. And so that's what I did. Yeah. So just to wrap up then. If you were only going to take away one slide, I hope that this would be the one that you took away from my talk, is that I truly believe that you get out out of the portfolio what you put in. If you do your portfolio and you see it as just pointless, reflective nonsense, just to pass the year, get ARCP outcome 1 and off you go, the e-portfolio will not be useful for you. And you will have to do e-portfolios for the rest of your clinical career. You will hate them and be miserable with it. But I'd challenge you to try and consider every day that you go out onto the wards, look at every patient and every senior interaction, every MDT member interaction as a learning opportunity. If you feel like it went well, or if you're getting verbally good feedback, which is kind of rare, not good feedback, just feedback generally, it's hard to get feedback. Reflect on the fact that it's good. What are you doing well? How can you continue doing well? If you're getting feedback that you're not doing so well, or that you felt like the interaction with the patient didn't go brilliantly, or getting constructive feedback, reflect on that too. That is just as valuable. What can you do better for next time? And if that's the way that you approach your portfolio, and you see it as a way to constantly evolve and develop to become both a better doctor and a better person, the portfolio will be absolutely invaluable to you. Not just a way to pass the year. Okay, all right, so I will wrap up there. Hopefully I've not spoken for too long. I'm very happy to answer questions in the Q&A now, and I've popped my email address on the board if anybody wanted to contact me directly as well. But thank you very much for listening.
Devon, thank you very much indeed. That was absolutely superb and really inspiring. We have time for just 1 or 2 questions, and I'm going to start and ask Debbie a question about how can you expand? We've come away from numbers of pieces of evidence in each foundation professional capability. Could you make a few comments on how supervisors and how foundation doctors know when they've put enough evidence in, or how much evidence they should put in, or what it should be like? Could you talk a little bit about, instead of the numbers of pieces of evidence, what is it that supervisors are looking for in each of the FPCs and across the HLOs to achieve their HLOs? Could you talk a little bit about that?
Yeah, thanks, Ruth. So I think having no minimum requirement necessarily sometimes can be tricky for doctors to navigate. I would say speak to your individual clinical supervisor about what their expectations are when looking for bodies of evidence, and a good mix across all the SLEs of mini KEXs, CBDs, DOPS. For instance, some people may think, oh, if I put up 5 pieces of evidence, but say they're 5 DOPS, all of similar caliber, 5 phenopunctures, ABGs, things like that. I think as a clinical supervisor, you probably wouldn't feel that is a broad enough body of evidence. So I would say aim for a mix across the 3 of case-based discussions, mini KEXs and DOPS. And again, all of different caliber, all of different encounters as well. There may be times where you can like a mini KEX to a DOPS, for instance, like a chest drain. That's a good learning event and a good DOPS as well. But I think probably speaking with your supervisors, and I would always say put in a little bit more than you think you need, so there's no doubt about the evidence that you've put in. Some people would say, I usually say a good ballpark is when you're in work, there is ample opportunity to get 1 SLE a week in some shape or form during your working hours. I know sometimes that can seem a little bit unrealistic, but certainly if I'm looking at a portfolio, I would expect a minimum of 6 pieces of evidence, and across the three types of SLEs. And reflection wise for each placement, I think, as Devon said, every day is an opportunity when you're F1, F2, and whenever throughout your medical career. So I would say a minimum of 2 or 3 reflective pieces of interactions or learning opportunities. Again, either linked to your SLEs or separate is probably a reasonable number.
Brilliant. Thank you very much, Debbie. I'm conscious we just have a couple of minutes left. I'll just add, don't forget about the Learn form, learning encounter and reflection note. I don't see it used too often, but it's very good for, say, simulation learning experiences, or it can be used instead of CPDs or mini KEXs. So, Devon, just in the last couple of minutes, could you talk a little bit, could you expand a little bit on feedback, which is really important, on the TAB, the team assessment of behaviour, and the placement supervision group, and how you see the difference in those, and what any recommendations you have on those? I know you talked about your sort of cheat book or whatever it's called to
Creepy book of names.
That's the one. So just the difference between a TAB and a PSG, and you have about 1 minute. Thanks.
Oh. So from my perspective, as a foundation doctor, a TAB form is more about how the multidisciplinary team sees you, and the PSG is how you are to supervise from the perspective of more senior doctors. Now, a TAB includes senior doctors as part of it, but it also includes allied healthcare professionals. It includes doctors more senior than F2s. It includes nurses and more senior doctors as well. Whereas a PSG just tends to be at least two senior doctors. From a TAB, I take away how I am to work with, and that's more like what your day-to-day is. Are you approachable? Do you do tasks when people come to you with them? Are you reassuring when you say, oh, that task doesn't need to be done right now? Do the team feel like you prioritize things appropriately? I feel like that's really useful on a day-to-day basis. The PSG is a little bit higher level, the way that I perceive the feedback from it, where it's more about, are you safe? Are you a good member of the team from a senior's perspective? Are you reliable? And I think that's also really, really useful feedback. But it's less about your day to day and more just what is the perception of you in the department that other people have. And you want to have a good, and you want to be easy to supervise as well. I personally found a TAB harder to fill in. It's why I have my creepy book of names, because different departments, you don't always necessarily work with different members of the MDT on a regular basis. In the wards, for example, I worked with other doctors all of the time. I was speaking to IMT 2, 3, 4 all of the time. Whereas in the emergency department where I am now, I very rarely speak to other doctors of my or a slightly higher level, whereas I always speak to the nurses and the allied healthcare professionals and the seniors. And so there's sometimes you struggle in different areas and different rotations. But you've got time to complete it. It doesn't all need to be done in one rotation. In fact, I would recommend that you don't do a TAB and a PSG in one rotation, because you're trying to see how you work in different environments. But yeah, you can just do it in another one if you feel like you're struggling for responses.
Brilliant, Devon. Thank you very much. And of course, the ARCP checklist is asking for 1 satisfactory TAB and 1 satisfactory PSG by the time you get to the end of May. And certainly, as it's October at the moment, I have to let you know that certainly in Northern Ireland, we recommend the TAB is done in the first placement, specifically in October. And then your PSG you then can do in your second placement, but none of those are musts as long as you get them done. It's just after 7 o'clock, so I am going to finish the webinar here. I would like to thank Debbie and Devon very, very much indeed for your contributions, which have been fantastic. I hope the foundation doctors and or supervisors who are out there have found it helpful. And I also hope that anybody who listens to it as a recording finds it helpful as well. And it just remains for me to wish everybody all the best. So thank you.